Hi everyone. Today on Quick Care Bites we'll be discussing ventilator dyssynchrony. The modern ventilator needs to be told when to start the breath, which is known as the trigger, what it needs to achieve with each breath, known as the limit, and when to stop the breath, which is known as the cycle. Patient ventilator dyssynchrony is therefore the uncoupling of a mechanically delivered breath from the patient's own intrinsic neural breath. Why care about patient ventilator dyssynchrony? It can have several harmful consequences. So ventilator-induced lung injury can occur together with patient self-inflicted lung injury, and both of these would increase the work of breathing, increase oxygen demand, cause the patient distress and discomfort, as well as increase the intracranial pressure. Dyssynchrony has been found to increase the length of mechanical ventilation and ICU stay, and possibly may even increase mortality. Dyssynchrony can occur because of high respiratory drive, examples of which would include flow starvation, premature cycling, or low respiratory drive, examples of which would include ineffective triggering, delayed cycling, or reverse triggering. Today, we will be discussing common dyssynchronies you may encounter in the ICU. As a recap, the mechanically delivered breath is composed of A, the trigger, B, the limit, and C, the cycle. Dyssynchrony can occur at any of these points of the breath. For trigger dyssynchrony, this would include ineffective triggering, auto-triggering, and reverse triggering. For limit dyssynchrony, a common example is that of flow starvation, where the ventilator delivers an inadequate flow to the patient's demand. Lastly, in cycle dyssynchrony, the ventilator can either cycle off too fast in expiration, which is known as premature cycling with resultant double triggering, or too slow into expiration, which is known as delayed cycling. The first dyssynchrony we will discuss today is that of the ineffective trigger. What happens in an ineffective trigger is that the patient's inspiratory effort does not trigger a machine-assisted breath. Although the patient is making a substantial inspiratory effort, the ventilator is unable to detect this request. And what you'll see is multiple negative deflections in the pressure time scaler, with corresponding positive deflections in the flow time scaler. And if esophageal pressure monitoring is employed, you will see negative pleural pressure deflections as the patient makes an inspiratory effort. Causes of ineffective trigger include dynamic hyperinflation, which is the most common cause we see in patients with asthma or COPD. Other causes include neuromuscular weakness, reduced respiratory drive due to oversedation, or that the flow trigger is said to be too insensitive, but this is rarely the case. The consequences of ineffective triggering are that of an increased work of breathing. It is uncomfortable for the patient and will result in prolonged weaning. This is another example of ineffective triggering, and it really is to illustrate that ineffective triggering can occur during any point of the respiratory cycle. It can occur during the expiration phase, as we see over here. So again, we see a negative deflection in the pressure time waveform and a positive deflection in the flow time waveform. But it can also occur during inspiration, in which we'll also see a negative deflection during the mechanically delivered breath, with a corresponding positive deflection in flow. One of the most common causes of ineffective trigger is that of dynamic hyperinflation. Looking at the bottom left picture, the normal flow time scaler will demonstrate a return of expiratory flow, which is the yellow component, back to the baseline of 0. What happens in dynamic hyperinflation is that the expiratory flow waveform will fail to return to 0, and we see an example of this over here by the pink and the red arrows. Other maneuvers to look for dynamic hyperinflation would include that of doing an end expiratory pause to measure intrinsic PEEP. You can also look at the area under the curve of the flow time waveform, as this corresponds to tidal volume, where the inspiratory tidal volume is larger than the expiratory tidal volume. Lastly, increasing plateau pressure also signifies dynamic hyperinflation, as it represents decreasing lung compliance as lung units are overdistended. For ineffective trigger due to dynamic hyperinflation, some of the strategies to mitigate this would be to decrease the amount of auto-PEEP by allowing for more expiratory time. This can be achieved by reducing the respiratory rate, shortening the inspiratory time, reducing the tidal volume, or bronchodilating the patient. Another strategy would actually be to apply external PEEP to reduce the amount of effort the patient needs to trigger the ventilator. To apply PEEP to reduce ineffective trigger in patients with obstructive airways disease, we usually set the PEEP to be 50 to 80% of the intrinsic PEEP. As long as the applied PEEP is less than intrinsic PEEP, it will not worsen intrinsic PEEP by the waterfall theory. So how this works is it actually reduces the patient's inspiratory effort required to trigger the ventilator. If we look at the left panel, we see the external PEEP is set at 6 and the trigger threshold is set at 2 below that level, which is 4. And the patient only needs to generate a pressure of 2 to actually trigger the machine. In contrast, if there was no external PEEP being applied, a patient with a similar trigger threshold of 2 below that level will have to generate a pressure difference of 8 to actually trigger the ventilator. Other strategies to stop ineffective trigger would be to reduce sedation if patients are over-sedated, or to increase trigger sensitivity by making this number over here, which is circled in red, smaller, and this applies to both a flow or pressure triggered mode. The next trigger dysynchrony is that of auto-trigger, whereby the ventilator delivers a breath even though the patient is not making any inspiratory effort. So we can see here in this graphic an example of patient-triggered breaths with a negative deflection before the breaths that are triggered by the patient. However, we see many breaths that do not have this negative deflection before, and when we look at the esophageal pressure, there is no negative deflection, and these are actually auto-triggering from the machine. Causes of auto-triggering include that of air leak, secretions, cardiac oscillations, hiccups, diaphragm myoclonus, as well as nebulizer treatment. So this is an example of auto-trigger that is due to air leak. We suspect air leak because the volume time waveform over here in these 5 breaths actually does not return to baseline. So in terms of air leak causing auto-trigger, it only occurs when the patient is in a flow-triggered mode of ventilation. It is less likely to occur when pressure trigger is used. The last trigger dysynchrony we will discuss is that of reverse trigger, where a ventilator-triggered breath is followed by a patient-triggered breath. It is associated with deep sedation. Postulated mechanisms include the brainstem respiratory center syncing with the mechanical breaths delivered by the ventilator, or that the machine-delivered breath stretches the chest wall, triggering the Herring-Brewer stretch reflex, which then triggers the patient to take a breath. The potential harm of reverse trigger is that of volume trauma. It is the postulated mechanism as to why ARDS patients in the Accuracies trial derived a mortality benefit when neuromuscular blockade was applied, in contrast to the Rose trial. Management of reverse trigger will include reducing sedation, applying neuromuscular blockade, or increasing the set respiratory rate. This is an example of reverse trigger. So we see here that there is a machine-delivered breath, so no negative deflection prior to the breath, no inspiratory effort as demonstrated by the esophageal pressure monitoring, and it is followed immediately by a patient-initiated breath. So we see inspiratory effort from the patient with a negative deflection in esophageal pressure, and we see a second breath that is taken by the patient. And the harms of this is volume trauma. So we see that the breath where there is a reverse trigger has a much larger tidal volume as compared to the breath without. Reverse triggering can look quite similar to double triggering, which we'll discuss later on. But to tell the difference, usually what happens in reverse triggering is that patients are usually deeply sedated, whereas patients who double trigger are usually more awake and have a high respiratory drive. For double triggering, usually both breaths are patient-initiated, but in reverse triggering, the initial breath is always machine-initiated. Moving on to limit dysynchrony, flow starvation occurs when the ventilator fails to meet the patient's flow demand, and this usually occurs in volume control mode, where the operator actually sets the flow. It is demonstrated by a drop in airway pressure. So if we look at the pressure time waveform here, we see a M shape starting to appear, reflecting that drop in pressure. Causes include that of a high respiratory drive from the patient or low ventilator settings. And what results is the Pendeluft effect, with high volumes of air movement from non-dependent to dependent parts of the lungs as part of a patient's self-inflicted lung injury. This is another example of flow starvation, where we see a drop in airway pressure during the inspiratory component of a breath. And what this diagram is trying to illustrate is that when the patient has flow starvation, their extra inspiratory effort that causes the drop in airway pressure actually increases the work of breathing, and this work of breathing is actually reflected by this area under the curve of where the normal curve should actually be. Strategies to solve flow starvation include changing to pressure control, where flow is regulated by the patient, increasing tidal volume, increasing flow, sedating the patient in a bid to suppress their respiratory drive, or even paralyzing the patient. So what you do actually depends on what the patient's condition is. If the patient has just been admitted with worsening ARDS and you need to adhere to low tidal volume strategy, then you may require to deeply sedate the patient and consider paralysis. However, if you are weaning the patient and the patient is getting better, consider changing to pressure control, increasing tidal volume, or increasing flow. The next dyssynchrony also occurs in patients with high respiratory drive. In double triggering, there are two inspiratory cycles separated by a very short expiratory time. The expiratory time is usually less than 1/2 of the mean inspiratory time, and it occurs because the machine's inspiratory time is much shorter than the patient's inspiratory time. It leads to larger tidal volumes and breath stacking and can result in volume trauma. This is an example of double triggering, where the machine's inspiratory time is less than the patient's inspiratory time. In a patient with high ventilatory demand, they want to breathe in longer. So what happens is that as the patient continues to breathe in and breathes in very hard, this causes a negative pressure deflection while the machine is actually trying to cycle off into expiration, and the machine senses this negative pressure and gives another breath. It happens in ACPC because the mechanical inspiratory time is too short, i.e. we set the TI too low. In ACVC, it may also result because of flow starvation, where flow starvation may actually trigger another breath, and it usually occurs because tidal volumes are much lower than what the patient wants. Strategies to deal with double triggering will either involve increasing the machine's inspiratory time or reducing the neural inspiratory time of the patient. So how we increase machine's inspiratory time depends on what mode you're in. If you're in PCV, you will increase TI. If you're in VCV, you will increase the tidal volume or reduce the flow because inspiratory time equals to volume over flow. In pressure support, you will consider lowering the cycle threshold so that the patient has a longer breath. You may increase the pressure support or choose a lower, slower rise time. To reduce the patient's own neural inspiratory time, you can choose to sedate the patient more deeply. The next dyssynchrony is also a result of a mismatch between machine inspiratory time and the neural inspiratory time of the patient. In premature cycling, the machine cycles off into expiration even though the patient wants to continue breathing in. This means that the inspiratory time of the machine is lower than the inspiratory time of the patient. And why this happens in patients is that either the patient has a very high ventilatory demand, or that on the ventilator we set a low tidal volume, we set a short inspiratory time, or the patient is in pressure support mode. So what we see in premature cycling is that there is a positive deflection in expiratory flow, denoted here by the red arrows. And this suggests that the patient wants to continue inspiration, but the machine is already in the expiration. So this positive deflection in the expiratory flow corresponds to a negative deflection in the pressure time waveform. So premature cycling is commonly seen in pressure support mode, and this is because pressure support mode is a flow cycle mode of ventilation. So normally, the breath cycles off in PS when flow reaches 25% of the peak inspiratory flow rate. Premature termination of the breath may occur if the set threshold is too high, or if there is a decrease in lung compliance, which causes flow to drop very quickly. So again, looking at the picture on the right, we see these positive deflections in the flow time waveform that correspond to negative deflections in the pressure time waveform that occur within expiration. And this is actually the patient trying to continue to breathe in as the machine has already cycled off into expiration. If we increase the E-sense setting, this will actually solve the problem of premature cycling. Solutions to premature cycling are quite similar to that of double triggering, where you try to either increase the machine's inspiratory time or you try to reduce the patient's own neural inspiratory time. Specifically in pressure support, you can try to lower the cycle threshold, increase pressure support, choose a slower rise time, or lower PEEP as this alters respiratory system compliance and the slope of inspiratory flow. The last dyssynchrony we will discuss today is delayed cycling. So delayed cycling is the opposite of premature cycling, whereby the machine's inspiratory time is longer than the patient's inspiratory time. The ventilator continues inspiration when the patient has already started to expire, and this usually occurs in pressure support mode. So what we see in the ventilator will be a positive blip in the pressure time curve. So recall that a normal pressure time curve is usually a rectangle. But over here we see a positive blip, denoted by the red arrows. And what this reflects is the patient trying to actively exhale, but the ventilator is still delivering the breath. Remember that our own efforts at expiration generate positive pressure. So causes of delayed cycling would include leaks or patients who have COPD, because COPD causes an increase in resistance and compliance of the lung. And the harms of delayed cycling is that it can actually result in dynamic hyperinflation. This picture shows another example of delayed cycling. So the patient is spontaneously breathing. We can see negative deflections in the esophageal pressure monitoring. But what we see is this terminal upward deflection in the pressure time scaler. And this represents the patient trying to actively exhale, but the machine is still in inspiration. Delayed cycling can be due to a leak. So if there is a leak in the system, the pressures on the left of the leak and on the right of the leak can never equalize. In extreme cases, where the pressures don't equalize, flow will never come to zero and the breath will continue forever. This is an example of a ventilator graphic in a patient with delayed cycling due to a leak. So we see that the breath occurs over a very, very long period, and we see that suddenly it cycles off into expiration when the flow does not really hit zero. Delayed cycling can also occur in COPD patients. In COPD, there is high airways resistance and there is also high lung compliance. This is because of destruction of the elastic fibers that actually support the lung. Peak flows are therefore very slow, and a long period must pass before flow drops to 25% of the peak inspiratory flow. The solution, therefore, will be to actually increase the E-sense or to use a preset cycle time. Looking at the picture on the bottom half of the screen, we can see that by increasing the E-sense on the right-hand part of the picture, this actually results in termination criteria meeting the patient's need. This is an example of delayed cycling occurring in COPD due to the high compliance and resistance of the respiratory system. How do we deal with delayed cycling? So you try to decrease the machine's inspiratory time. So depending on what mode of ventilation you are in PCV you will decrease the TI, in VCV you will decrease the tidal volume, and in PS you will actually increase the cycling threshold, which is over here at 25%. You might increase it to something like 50%. Otherwise, you should try to address the underlying cause, which may be due to leaks, or in a COPD patient to try and bronchodilate them. With that, we've come to the end of today's session. We discussed what is patient ventilator dyssynchrony, the harmful consequences, the common types of dyssynchrony we might see, and their respective solutions. For further reading, I would recommend these two articles by Gilstrap and Hess respectively. And a credit to Dr. Jason Phua and Dr. Eddie Tan should be given for some of the ventilator graphics used in this talk.